Started. We have 46 people. Thank you for joining us. Really happy to have you with us. If you are still logging in, and well, let's see, if you've logged in for the audio portion, you did not use the please call me option in the WebEx software as it popped up on your screen, you may want to take a minute, hang up, dial back in, and use that option. That's better for you to be able to chat with us and connects you to the whole platform and lets you use all the services that are part of your participation. Let's see. Yeah, and do use your, if you really can only join us by phone, please use your attendee number so that you can use more of the services. All righty. So for housekeeping, we are recording this session. The slides and the recording for Jennifer and for anyone else, the slides and the recording will be available on the CIN website afterwards. And again, if you have logistical questions, if there's problems with either the audio or the visual part of the presentation today, you can use chat. You can also use chat just to the host, and that'll keep it with us backstage here. Otherwise, if you have questions for the speakers, feel free to chat those in at any point during the hour. We're going to pause for questions twice, once at about 5 minutes to 1, or maybe at the top of the hour, within the presentations that we're going to get, and then we're going to pause for questions about 10 minutes before the end. So there will be 2 periods, but just chat in your questions anytime a question arises for you, and we will get to as many of those as we can. Do please stick around to complete I think it's a 3-question survey at the end of the webinar via the software here. That does help us. We actually really do use that information to help decide how to make these webinars better and more useful for you as we go forward. All righty. Let's see. So we have 4 speakers for you today. From Maternal Mental Health Now is what that some of those letters down there mean. In front of you right now you see Dr. Karen Post. She's the Executive Director of Maternal Mental Health Now based in the LA area. She's a clinical psychologist and psychotherapist with more than 25 years of experience, so really happy to have her. Gabrielle Kaufman is a board-certified dance movement therapist and professional clinical counselor. She has done a lot of work. She's also the training director for Maternal Mental Health Now. Her background includes lots of work both with individuals and groups for new parents, new moms, and single parents. So that's some of her background with maternal mental health. And then we have 2 other speakers. We have Joe Bloomfield, who is an attorney who has great mental health advocacy experience. And she's the policy director for Maternal Mental Health Now. And then we have Dr. Camilo Zaks, who's the medical director and CMO at USC Eisner Family Medicine Clinic. He will describe the pilot of improving and coordinating maternal mental health services that has been a real launching pad and a successful pilot for improving maternal mental health and primary care that happens at his clinic at USC Eisner. And he also is an assistant professor, as well as being the medical director and CMO. He's an assistant professor of clinical family medicine at the Keck School of Medicine there at USC. So I invite you, as we turn it over to them, I invite you to take another bite of your lunch. Give yourself the luxury of a full hour to focus on this really interesting topic and the great resources and opportunities that Maternal Mental Health Now has for us as the primary care network of California, and think about how you can apply these resources. You'll hear it's an amazing, a rich array of certification, instruction, consultations, toolkits, posters for promoting maternal mental health, a lot of amazing resources that they pulled together that we've got for you today as part of this production of the California Improvement Network. So Gabrielle has the ball now. So Gabrielle, if you want to take it away and help your team run through your presentation.
Thank you so much, Hunter, and thank you for the very kind and thorough presentation of our backgrounds and of some of the exciting work we're doing here in Los Angeles. We are extremely excited to share this hour with you all and appreciate the time that you're giving us. So I'm going to launch right into our presentation. So before we go anywhere, we just want to define a couple of topics, a couple of phrases that we use a lot. We say perinatal mood and anxiety disorders. The reason we use perinatal rather than maternal is that we are trying to look at how men and women may be impacted. However, the focus of our work tends often to be on women. We use the words mood and anxiety because we know that most women who experience perinatal depression also have some amount of anxiety. And we know that while there are other diagnoses we want to pay attention to, like bipolar disorder, post-traumatic stress disorder, or psychosis, those are not the majority of the presentation. In fact, most women seem to struggle with anxiety, which can be really crippling. And then I want to talk a little bit about this perinatal period that we look at. We look at from conception, and it used to be that we would say 1 year, but now we look further. We look more out into a 2-year period. And it isn't really simply because the symptoms present so late. It's because very often women don't get the help they need until much later on. So I want to take a moment to look at how common perinatal mood and anxiety disorders are. They might use the acronym PMADS, but it means perinatal mood and anxiety disorder. So what are the numbers? When we look kind of on a national average, they range from between 10 and 15% of pregnant and new mothers will experience some kind of clinical symptoms of depression. But when we start to look closer, and we are partnered here in Los Angeles with the Department of Public Health, they do a survey every year called the Los Angeles Mommy Baby Survey, LAM survey. And the numbers that they have gotten of women who self-report their levels of depression and anxiety tend to be much higher. In fact, when we look at the lower income ethnic minority groups of Los Angeles, such as African American women and Latino women, we're looking at numbers closer to 47%. When we talk about some of the partnerships and relationships and integrated care models that we have worked on here in Los Angeles, most of them meet those criteria, are in lower income, and also are in the ethnic minority higher risk categories. So let me take a moment to talk about what I mean by higher risk categories. Higher risk categories include teenagers, single moms, women who are either in the military as military members themselves or spouses of the military, women in low income, and the numbers we're looking at are women who report household earnings under $20,000 a year. Socially isolated women, and what we mean by that are women who tend not to have communities, and some of whom may be that way because they are recent immigrants, maybe because they don't have the same language or culture in the community that they're living now as where they were originally. And then there are other reasons for social isolation. We also pay attention to women who have high-risk pregnancies, infertility problems, or women who have had difficult deliveries or with sick babies who might be in the neonatal intensive care unit. In fact, what we found is those numbers are really quite high. So now the question is why? Why is this an issue? Why do we want to spend the time talking about it? How does this issue kind of impact the families that we're serving? And we obviously know to look at the mother, but I want to invite us to look a little bit further, which is how might it impact the fetus? We know that anxiety and stress during pregnancy can have negative outcomes for delivery and can have problems with the newborn as well. We look at early delivery, we look at low birth weight, we look at other neonatal health problems. We also notice that the infant and child may have some difficulties with adjustment, with behavior, with health problems if the parent is struggling with a perinatal mood and anxiety disorder. And we also, we also notice that the attachment relationship, which is that relationship that a child, a newborn, has to their primary caregiver, can be impacted if that primary caregiver is struggling with depression or anxiety. And finally, we really want to take some time to pay attention to how not only is the infant and mother impacted, but the entire family, and that family may be even multi-generationally. We have looked at some of the families we've served and noticed that it might be that that these issues have been part of their lives for a while. We also know if left untreated, they can become chronic. So I'm going to pass it over to Dr. Post.
Hi, everyone. I just wanted to speak for a moment about what the goals of our organization are. And Maternal Mental Health Now, we see ourselves as an agent of change. And what we don't do direct service. What we do is provide training and technical assistance, systems change, public awareness to many sectors of both the medical health delivery system and other sectors as well, child welfare, early intervention. And what we aim to do is raise awareness and improve the prevention, recognition, and treatment of perinatal mood and anxiety disorders, and to help each woman and each family experience a happy, healthy pregnancy and postpartum period. And critically, we want to make it possible for each child to bond with a loving and attentive caregiver, primary caregiver, whether that be the mother, the father, the grandmother. And we want to help each family enjoy a smoother transition to parenthood. It's the most vulnerable time, both in a woman's life, a newborn's life, and a family's life. And then we are aiming to affect the whole system of care and align efforts both county-wide and statewide to be able to provide greater access to care for all women and their families. And our services include training and technical assistance to all the sectors that I mentioned, and that includes helping medical sites with integration. Our resource directory, which is a model we're hoping to spread throughout the state as well, which is an interactive, searchable online directory for perinatal mood specialists, our policy and advocacy programs, and our public awareness materials and events, which we'll talk about later. And now I'm going to turn it over to Jo Bloomfield, our policy director.
Hi, everyone. I just wanted to speak a minute about our integrated care initiative as a whole. You're going to hear today a lot about our program at USC Eisner Family Medicine Clinic, but we have a lot of other partnerships with FQHCs, county health system, hospitals, other medical settings, and this slide lists just a few of those in settings as varied as pediatrics, obstetrics, family medicine. And they're all doing it in a different way, and we're going to talk a little bit more about that later. But I just wanted to highlight one of them. Harbor Community Clinic is an FQHC in San Pedro, and we started an integrated care pilot there in March in their obstetrics and pediatrics departments. And I just wanted to share some preliminary data with you. They've, since March, screened 120 perinatal patients. 75% report income of $20,000 or less, and 25% have screened positive. So these are women that the clinic would not have recognized prior to our pilot and are now getting the services they need. I'm now going to turn it over to Dr. Zaks to talk a lot more about the new family care team at USC Eisner.
Hi.
And Dr. Zaks, just let me know when you'd like me to forward the slides. Would you let me know when you'd like me to forward the slides, okay?
Okay, will do. So my name is Camilo Zaks. Just a quick clarification on my credentials. I'm not the CMO of USC Eisner because we exist as part of the Eisner Pediatrics and Family Medicine Center, which when we're a small part of that, which may come in when we go over the project. But I'm going to talk a bit about our pilot program, the New Family Care Team. Next slide, please. So the New Family Care Team was a collaboration between Maternal Mental Health Now and the USC Eisner Family Medicine Center in downtown Los Angeles. Where we are located and our patients' kind of general illness population, we have a depression, our perinatal patients have a depression rate of 30 to 40%, which is more than twice the national average. The goal of the New Family Care Team was to reduce that rate and to create a model that could spread to other sites. Next slide. It's based on, the New Family Care Team was based on the impact model, which is often called collaborative care, where mental health services are embedded within the primary care center. In our situation, we also had psychiatric specialty care support as someone we could consult with. We had step care with services based on risk and need. We had a multidisciplinary team having weekly care team meetings. The impact model has been well established for other mental health conditions, had not been done previously for perinatal mood or anxiety disorders. The goals were to break down barriers of stigma, transportation and logistical barriers, including childcare and fragmented care. By housing all the services in one location that the patients were already familiar with, the goal was to really make it much more, to make the mental health services much more accessible to the patient, as well as to improve screening and identification of illness. Next slide. So how did it work? Okay, we had screening of all women who were pregnant from the first prenatal visit through the first year of the child's life. All women with positive screens were then assessed by a physician. There was risk stratification based on the assessment. Interventions were then delivered according to the level of need or risk, including psychoeducation, case management, psychotherapy, and medication. We were able to give psychiatric medications with consultation of the psychiatrist. Next slide, please. So, the 4 W's and the H. How is it all done? What are the details? Next slide, please. So the screens that we performed were PHQ-9s with Edinburgh 3. They were performed by our medical assistants in clinic at triage. At the same time they were vitaling the patients, they would give the patients a clipboard, and then they would kind of self-assess, and if there were any literacy issues, then the medical assistant would sit with them and go over the questions one by one. The social work, we actually had social work students under the guidance of a LCSW. They would perform a full psychological assessment. There would be case review with interdisciplinary interprofessional care teams, which met weekly, including the medical director, other primary care physicians, the psychiatric consultant, the perinatal and mental health consultants, case manager, social worker, and social work interns. Again, the interventions included psychopharmacology, case management, psychotherapy, referrals, and a lot of self-care and counseling. At times, we also had some occupational therapy students and occupational therapists on the team as well, though that wasn't for the entire duration. Screening occurred during prenatal visits at the initial visit as well as each trimester. As you know, there are upwards of, full prenatal care is at least 10 visits, so it was not our goal to overwhelm women with a screening every visit. We wanted to make sure that we were doing it regularly. Screens also occurred at the postpartum visits, and then when moms would bring their new babies in for their well-child exams, we would screen during the well-child exams for the first year. Counseling sessions were based on the treatment plan and would be scheduled as needed based on the treatment plan. Okay, next slide. So why integrated care? To increase treatment engagement, to reduce stigma, to increase communication between medical and behavioral health. This was really, really helpful to be able to have knowledgeable people in the room at the same table talking about the same patient and understanding how the different problems, the mental health issues impacted the medical care, how the medical care impacted the mental health issues. Increasing the integration between the maternal and child systems, providing additional resources, and decreasing the expense of the family and system. Really a big part of this, again, is improving access to these services. Next slide. WHO universal screening. So this was opt-out. Basically, these forms would be tagged to every chart for every pregnant patient, unless they'd already had it during that trimester. So all pregnant women and all postpartum women, including at the well-child visits, these forms would be tagged to the well-child paperwork. The partners involved in the care included all the medical staff, all the medical assistants, the physicians, occupational therapists, social work and case managers, consultants, our reproductive psychiatrist, Dr. Dossett, who's amazing. There were various team members who were involved in data collection, and of course we had to have administrative support for this as well. Next slide. We had weekly interprofessional care team meetings on every Monday afternoon, which involved case reviews and treatment planning. Their perinatal psychiatrist would provide recommendations in terms of psychoactive medications that would then be implemented by the medical director as well as the treating physician. Because USC Eisner is a residency clinic, the resident physicians are the majority of the primary care providers within our clinic. Psychotherapeutic interventions, because we were working with social work interns as usually the main direct therapist for the patient, a lot of times there would be different suggestions from psychologists, from other members of the care team about psychotherapeutic interventions. And we would also be able to do referrals through case management. Next slide. Okay. So what do we make of all this? I think one of the big findings for me was that we were identifying so many more patients through the universal screening than we were prior to that. And there were not dramatic changes in our patient population. It was pretty much the same patients. We were just picking it up much better. Our gut level assessment is just not enough alone. And having a standardized method of screening is truly necessary. We identified a lot of chronic mental health concerns that we would not have identified otherwise. Patients who had at some point in their life previously been told that they had bipolar or schizophrenia and did not bring it up during the initial OB visit when they scored a positive PHQ-9 and then met with a social work intern would reveal that they've had a mental health diagnosis in the past, and that was really enlightening. Communication is key. Everybody needs to know what's going on and have regular updates. There was a lot of confusion throughout the process that only really got better once we started talking to each other more. Implementation lessons learned. We went through the transition to an EMR in the middle of a pilot and had to adopt and develop new ways to track the patients to integrate with our EMR. Every team member is essential, and especially the medical assistants, that the patients often will kind of sidebar the medical assistants and let them know things that they would not necessarily feel comfortable directly letting the physician know. And then, this is something I said earlier, I guess, when we were talking about this. The new family care team changed not only how we provided care for our perinatal patients, but for all of our patients clinic-wide. And I really, truly believe that this has improved how we are delivering mental health services for all of our patients here in our family medicine clinic, not just our pregnant and perinatal patients, but our older adults, our teens, everybody, I think, has really benefited from the improvements in lines of communication and collaborative care that we've been able to make because of this project. So thank you for including us in this project. Next slide. I'm supposed to hand off to someone else, but I don't have it in front of me who's next.
So no, it's okay. I think, Hunter, were you going to have us have questions for Dr. Zaks at this point?
Yes, let's pause. So let's see, we have 75 people logged in. I'm sure there are questions in your mind about anything that's been said so far. You've heard from 3 or all 4 of the team members at Maternal Mental Health about the importance of perinatal mental health, how it's not just about the moms, kind of the timeline they look at going from 1 year to 2 year, trying to help folks. And then, you know, the Eisner pilot, Dr. Zaks gave some really good examples of, or good detail about how it rolled out in their clinic, some wonderful positive spillover effects that happened for other types of needs people had besides maternal mental health concerns. So please chat in, and we'll get to 3 or 4 now, and then we'll save the rest for for the end of the hour. So let's see, Sue is asking, on average, how long did the individual psychotherapy last? So maybe this is a question for both Dr. Zaks about how things played out in their pilot, and then also for, I would think, Dr. Post about kind of maybe if there are some recommendations or what the variables are for how long therapy should last. So maybe let's start with Dr. Zaks.
In general, once we identified a patient and we tracked them, we continued to provide services for them throughout their pregnancy and usually followed them for a year postpartum. Sometimes it became, and the other team member, Karen and Gabrielle, were involved in this too, so maybe they have better recollection, but in general, even when things seemed to improve, we tried to keep a close eye on them, and having the therapy team continue to work with them was an important part of that, but usually up until a year postpartum, at which point we would kind of provide services as needed.
Great, thank you.
I just would add to it, this is Gabrielle, and I would say Dr. Zaks is exactly right, that once they kind of were flagged and receiving some services, it gave us the opportunity to continue to monitor. However, some people just needed a decreased level of care once they started to stabilize.
Great, thank you. Okay, and then Jessica asks, what part does OT, occupational therapy, play in the care team?
So we have an occupational therapist at our clinic who was a faculty member at the USC School of Occupational Therapy. And at the USC School of Occupational Therapy, they have a little bit of a different perspective about what OT's role is in the medical world. And one of they're big proponents of this concept of lifestyle redesign, where it really becomes more of kind of a hybrid of kind of problem-based therapy and kind of life coaching, where when patients have need to kind of get engaged in some behavioral activation or behavior change, they kind of go through a specific set of activities about what they're doing in their day and do a lot of kind of like life planning. So our OT faculty member was really interested in the project and got really engaged and had her OT residents and OT students working with some of these patients on building some skills in terms of kind of life planning.
And I just wanted to add to that, there was a unique contribution there from occupational therapy and their unique perspective, as Dr. Zaks said, of lifestyle redesign. And that's also related to one of the interventions that was commonly used by the social worker or social worker intern, and that was a solutions-focused or problem-focused approach to psychotherapy as well.
And this is Gabrielle saying one more thing. I wanted to share how one other wonderful way in which the occupational therapist helped was sometimes when they were working directly with the child or infant, they were able to target what was going on with the infant and at the same time recognize how the parent might be struggling with depression. So they may not have been previously identified, but in that partnership and involving them in the team, we were able to link.
Great, thanks for all those good points. Susan asks, how can we screen better for postpartum depression before the client has the baby?
How do you anticipate postpartum depression before the client has the baby? I'm just trying to understand the question.
I think so. Maybe Susan confirms, yes, that's what she's asking.
Okay. Well, we found this to be pretty effective in terms of using the PHQ-9 and the Edinburgh-3 as universal screening tools. If you wanted to do more than that, you could do it at every visit, I guess. But I felt this was pretty effective. I don't know if the other team members have any insights on that.
So what I would say is, Yeah, I'm not sure if I understand it correctly, that we know that untreated depression or anxiety during pregnancy has a very high risk of a postpartum manifestation. So by involving the prenatal care team in regular screenings, we were able to identify and provide treatment, increasing the likelihood that someone would be doing much better in the postpartum period.
The other thing I would just add in again is when doing an initial assessment, initial OB assessment, making sure to inquire about any mental health history, including a history of previous postpartum depression or symptoms that might have been undiagnosed postpartum depression after a previous pregnancy.
In addition, there are many risk factors, and those clinics might not always have the time to ask about them, but in comprehensive perinatal services and other programs where clinics have the opportunity to ask about the risk factors, such as, like Dr. Zaks was saying, a history of prior mental illness or a history of loss or trauma, which is very prevalent throughout our patient population, but in low-income populations especially. These are all risk factors for a postpartum depression as well.
Great, thank you. Thank you. Okay, let's do one more, and then we can save any other ones for in another 20 minutes or so. So let's see. Jennifer, who's a grad school student who's writing a paper, who's going to reference our webinar today, which is great. She asks, was any of the therapy intervention provided as group, or was it only individual? And if group, what was the group called? Any efforts to name it to reduce stigma? And the third question, was there any direct? Well, let's save that third question for later. So group or individual, and if group, what special thought was given to how the group was named?
Individual only.
Okay.
But I do want to say we did home visitations as well. So on the early part of this pilot, we tried to get some support groups going. Support groups are very difficult to get started, and so we really had some difficulty with traction. And Jennifer, your question is a good one about naming a group. There's two schools of thoughts about it. One is to directly call it a group for women struggling with depression and postpartum, so that we help to reduce the stigma by naming it. And then there are other people who just call it a new moms group. So there are different theories, and I'm happy to explore that further with you if you like off this conversation.
Great, thank you. And let's do one more because it's specifically related to the pilot and because I accidentally skipped it. It's how was the pilot program initially presented to the hospital? So maybe something about Tiffany may be wondering about how you made the case to make the pilot go. How it was sold to the institution?
So that's a great question, and I think in this case it started with an internal champion, a medical director. Prior to Dr. Zaks being the medical director, Dr. Brian Prestwich was, and he already had an interest in perinatal mental health. And yet, nonetheless, initially, it was a sell to the rest of the clinic, and doctors and staff had to be brought on slowly so that they would have buy-in. You have different levels of buy-in to this issue. The research has so accumulated as to demonstrate the importance of capturing and responding to a pregnant and new mom's mental health needs, that a lot of doctors are very aware of this and wanting to do something about it, and a lot of clinics, and at the same time others are not, and there are barriers. We don't have the time. What will we do? How will we pull it together? So being able to bring in our services, our consultation services, was helpful as well. And then when Dr. Zaks came on board, he also shared a passion and interest in this issue. So we were able to take the pilot even further and deeper at that time.
Great, thank you. So we have 1, 2, 3, 4 questions keep coming in. We're going to save them for the end. So I'll turn it back to you folks on Maternal Mental Health now to finish your presentation. And if we can, I don't know if you'll be able to wrap up by, I don't know, 1:18 or 1:20. We'll get to as many more questions as we can. So as you keep having them, please keep chatting them in, everybody. Thanks for all your participation so far.
Okay, great. So I think the important issue that we're talking about is integrating mental health integration, which is happening more and more, and the Affordable Care Act is encouraging, and probably why many of you have joined this call in terms of why do we want to integrate maternal mental health in general. And the evidence is pretty strong that by integrating the mental health, and in this case the maternal mental health of a patient, a whole person feels engaged in a more comprehensive way, and they're more likely, therefore, to engage and see their clinic as a medical home. They're more likely to avail themselves of services and have a dedicated commitment to the clinic. And that's very helpful in promoting all kinds of health outcomes. In terms of, it's interesting, this slide is interesting to look at in terms of levels of integration, of maternal mental health integration. And the purpose of this slide is not to say necessarily that anybody should be on level 5 or needs to be there or even necessarily wants to be there, but to demonstrate and illustrate the different levels of integration so that you can self-assess and see where your clinic is at, where you think it might be, and also to consider where you might want to go next. And once you know that, then there are steps you can take to get to the next level. But first, it's important to see where you are in the roadmap. The first level is minimal collaboration, and this is usually what we're used to, and it's when healthcare and mental health providers work in separate facilities and they rarely communicate about individual cases. The second level is basic collaboration, and so there are still separate sites, and then there is communication sometimes about shared patients and the capacity to use each other as resources. And then on level 3, it's really the first on-site level of collaboration. And sometimes that can be called or looked at as co-location or embedded services. And so the facility is shared. You may have a mental health professional from a county mental health service, and they may share the facility, but there are different systems. They belong to different systems, and they haven't developed any shared communication or systems regarding the patient yet, and they don't necessarily have regular face-to-face meetings. And sometimes what happens with this, and this has been one of the difficulties with integration, is that folks can feel, well, if we have a mental health professional there, and mental health can feel that way, and medical health can feel that way, then we're going to be able to integrate. And that's not necessarily so. We hear over and over again that sometimes the mental health person will just sit there and actually never get referrals. And that's why integration itself is so important. So when close collaboration happens on level 4, we're talking about a partially integrated system where there's some sharing of communication between the two systems and regular face-to-face interactions and some coordinated treatment plans for complex patients. And everybody, there is a basic understanding of what each discipline does. You know, ultimately, close collaboration is a fully integrated system for physical and behavioral health, and where the so-called mind-body issues are not considered separately, but rather you have a whole person, a whole patient, and share systems. You're on the same team, you communicate regularly on the same site, and have an overall vision where the understanding how physical health can impact emotional health and vice versa, and also a very in-depth understanding of each other's roles and responsibilities. So I'm going to turn this over to Gabrielle now.
Thanks, Karen. So I want to just take a moment to talk a little bit about our training and technical assistance model. And one of the things that we at Maternal Mental Health now have learned by error is that when we originally started and provided trainings, it just wasn't enough to tell people a little bit about the issue. Instead, we found that we needed to not only give a training, but to be able to take some steps so that people could take the learning and integrate it in their setting. And each and every setting we have partnered with is different, so their needs are different. A community mental health center, for example, is different than a family medicine clinic, such as USC Eisner Family Medicine. So when we were working to create trainings, we make sure that those trainings are tailored towards the audience and towards the needs of the community and the services that they provide. What we found with some of the technical assistance we're providing is that there's an increase in screening rates, an increase in referral rates, and also at the greatest level, an increase in capacity to serve the women who are struggling. So when we talk about some of the technical assistance, some of the steps we've taken are consultation on integration, which is what we really got into in our wonderful work with Dr. Zaks and the team at USC Eisner Family Medicine, which was this real involved, integrated kind of modeling of a program together and providing kind of ongoing mentoring, coaching, and then kind of reflective opportunities. How is this going? What needs need to be assessed and changed? We helped also in some other settings to kind of review general intake processes and how can we help individual programs to change their screening tools and intake so that they would be able to adapt to this new change. And then we do some, as Dr. Zaks referred to, we have Dr. Emily Dossett, who has worked with us, as well as some other wonderful reproductive psychiatrists who can give some consultation on the nuances of perinatal medication management. Finally, we have put on some trainings and such as a trauma-informed care conference that's upcoming, and some e-learning opportunities and other certification training so that people can come through our training with some sense of competence and understanding of the issue. So I'm now going to pass this on to Joe Bluefield.
So I'm going to talk quickly about our resource directory. And this came about for, I mean, we'd always wanted to have a resource directory, but the most important impetus behind it was, and a lot of you may be in this position, is you're not able to fully integrate, but you want to start screening patients, but you have no idea where to refer them to. And that is a fear among many providers. So we created this online resource directory, and most of our providers on the resource directory come from people that Gabrielle and her team have trained. So the whole system is created from within and without. We currently have 220 resources on our directory. 2/3 of them offer low or no cost services, and we hope to keep that ratio for as long as its existence. You can search by type of service, down to nitty-gritty like dyadic therapy, so it's helpful for providers to find resources for their patients, but it can also be used for the public. You can search by language, age, and I wanted to say that we now have the infrastructure for this, and we would love for it to spread. So if you're interested in your community having its own resource directory, we would be happy to provide technical assistance on that. And now I'm going to turn it back to Gabrielle.
You'd never know that we were all three sitting together. I wanted to just take one moment. I referenced this, but I just wanted to say some of the exciting things that we're trying to do is what we found is that because we're such a small organization, being able to reach all the professionals that we really wanted to provide support for was going to be too difficult if we didn't rely on some internet support. So we have now launched an e-learning training, which is, has also been done in person as a 2-day certification, and you can find out more about it by going to our website. As well, we have created a healthcare provider toolkit, which is it's this wonderful toolkit that's got information about all that we've covered today and much, much more. Some information about diagnoses and treatment options and handouts, information in Spanish, information for dads, information for family members. So real kind of a nuts and bolts toolkit that we created, and that is also available on our website. And then we have a public awareness campaign.
So as Karen mentioned before, public awareness is one of our main goals to reduce the stigma that surrounds maternal mental health disorders. We have a ton of resources available for you if you'd like them for free. We have brochures, posters in 7 languages. If you go on our website, you can see and read. You can read some stories of members of our Speakers Bureau who are women who have experienced perinatal mood and anxiety disorders and now want to speak out to help other mothers. We host salons, which is a really wonderful peer-based facilitated training to help women understand their own stories with maternal mental health and to then share their stories in whichever way they feel comfortable with. We have PSAs, we do movie screenings, Mother's Day events, you name it. If it reduces stigma, we do it. And I know I'm just looking at time and I know we have a lot of questions. Could you go to the next slide? Oh, you did, sorry. We also have these policy briefs and papers on our website if you want more information about all of the things we're doing and all of our recommendations to make systems-wide change in Los Angeles and beyond. And excitingly, we will have a collaborative care paper that will talk a lot about the Eisner pilot, our other pilots that will be coming out in 2016. So please look out for that. I'm going to pass it to Karen.
I just wanted to say just 2 things and in terms of the resources that we have available to you. So Gabrielle mentioned our online certification training, which goes into more depth. And soon to be launched, we can keep you up to date about this, is going to be a psychiatric consultation service, because one of the barriers is that sites often don't have access. The primary care doctors and OBGYNs and pediatricians can and sometimes do feel comfortable with prescribing basic medication for depression and pregnancy and postpartum, but they understandably feel that they could benefit from consultation from a reproductive psychiatrist. So we're going to be beginning that service, and it's going to be web-based so that physicians can call in to the monthly meeting for consultation. So that's all I wanted to end with. Are there any questions? Or Hunter, are you going to be asking about the questions?
Great. Yeah, I've been able to combine some questions that have come in. So yeah, we are going to do a few more questions. You'll also see if, on the online portion, Lauren just activated the poll, so you can fill out the polling questions anytime. We're going to do another 10 minutes of Q&A, and then we'll for some good questions about funding and then initial screening for new moms, and then I'll wrap up with some other ways you can engage with the California Improvement Network. But just while we're on resources and looking at their web address there, you know, if it was worth your time to join the webinar, it's certainly worth your time to check out their website. It's very well organized. They just ran through a whole litany of ways that the resources, trainings, online certification. There's all this cool stuff they do. And it's very well organized. Most of it, the resources are pretty much all free. Not the training so much, I don't think, but the resources are. So get on there and check it out, and it's a great place to go for this kind of integrated care work. So let's see. So there was a question from Nicole about, she said she works with new moms at a hospital in labor and delivery and in the NICU, the neonatal ICU. Do you recommend a universal screening with PHQ-9 for those mothers in those places? Or is there, or should the staff there be doing some sort of initial, I don't know, tightening the group narrowing the group down based on indications of high risk?
So this is Gabrielle, and the answer is yes.
Yes, definitely. We recommend universal screening for all NICU moms, and also actually for all moms on labor and delivery floors. It really is ideal, and there are many hospitals that are screening all new mothers, period. But absolutely, the incidence of postpartum depression is so high for NICU moms.
And in terms of sectors that we are training, NICU nurses are at the top of the list.
Great. And is there a tool besides the PHQ-9 that you recommend?
So there's the Edinburgh Postnatal Depression Scale, the EPDS. What we have found is that the PHQ-9 is more readily available these days. Most healthcare systems are actually providing the PHQ-9 on their EMR in a general sense. So the great thing about the PHQ-9 is it's just already there. It's kind of ubiquitous in a lot of the healthcare settings. But the problem with the PHQ-9 is it does not ask about anxiety, and anxiety is the #1 way in which depression actually manifests in the perinatal period. So the Edinburgh 3 are the 3 questions we have taken from the Edinburgh scale. However, the Edinburgh scale is a 10-question scale, and it is also very good, and it is evidence-based.
And the Edinburgh 3, the anxiety subscale, is actually been validated for postpartum and prenatal anxiety.
There are other scales that are really good, but the great thing about the PHQ-9 and the Edinburgh is they're free and they're available in multiple languages.
That's great.
So in short, we like to use both the PHQ-9 and the Edinburgh 3 when possible. But the PHQ-9 is definitely very, very helpful.
Great, and thanks. There's some good back and forth between participants in the chat. I appreciate that as well. Now we're going to talk about financing. There are a couple questions about financing. So was there for the Eisner pilot or the other pilot you mentioned at the other LA area clinic that we know have happened or are going on now, was there extra funding brought to bear to help these services for integrated behavioral health for perinatal mental health needs? Was there extra funding brought to bear in those pilots, or did it use all existing resources? And also just what are your recommendations for figuring out how to do these enhanced services in a sustainable way with money?
This is Karen Post. I'll answer the first part about funding brought to the pilot, and I'll let Dr. Zaks, if he will, talk about how the pilot has been able to sustain itself using the existing resources at his clinic. So initially, we were able to bring grant funding in and to get the pilot started and to establish the multidisciplinary team at both USC Eisner and Harbor Community Clinic. And that funding enabled us to use our staff time. So for me as a psychologist, for Gabrielle as an expert counselor in perinatal mental health and a training facilitator, for Dr. Emily Dossett, the reproductive psychiatrist, and for social work interns, supervisors. So funding was definitely very instrumental in getting that pilot off the ground. And then some of our funding we use in wherever we go, but it helps us save to come in and just train. A lot of times we're just using the existing resources that a clinic, for example, UCLA Westwood may have, where their pediatricians are very interested in screening and referring and frontline responding, and we're simply coming in and training. So, Dr. Zaks, can you speak a little bit to the sustainability and how you were able to continue utilizing the resources that you have?
Yes. So what we've done since the pilot ended is we have now a full-time LCSW on staff. We've continued to do screening in the same way that we've done it before. So in terms of the screening, there's not really much cost associated with that. Once we kind of integrated it into our workflow and everybody knows how to do it and we have a good tracking mechanism, it's kind of just one more form that needs to get filled out. It's not a huge labor cost in that regard. And in terms of the on-site therapy that we provided through our LCSW, he's self-supporting. I mean, we're all in California, and in California, pregnant patients are going to have insurance, through Medi-Cal or other, and Medi-Cal does provide for mental health services. So he's able to bill to Medi-Cal for those services. There are kind of details about Medi-Cal and mental health HMOs and stuff like that that sometimes need to get worked out, but he's been able to support himself and support his position through caring for these patients, and then also other patients in the clinic, because we do have other patients who really benefit from having a therapist in-house. In terms of the psychiatric consultation, that's part that we've lost. Dr. Dawson, who was our reproductive psychiatrist, has moved on to other projects, developing a new family care clinic over at LA County, doing more to really promote this issue there. So that is a part that would not be really reimbursable, that would not be able to generate revenue to support itself. If you did have that piece, you'd have to figure out a way to kind of just budget it into your overall operating costs, or find grant support. But the therapy part, we know he supports himself with the work he does.
And our hope is, because of what Dr. Zaks mentioned about the difficulty in finding, not everybody has a perinatal psychiatrist to consult with, and that's why we're beginning this consultation service specifically geared toward psychopharmacological consultation around perinatal patients.
Great, thank you, I appreciate that. Let's see, there's a couple more questions. A question from Denise that I'm afraid we're not going to be able to get to. Please use the contact options on the Maternal Mental Health Now website for any future. Please use their website to figure out how you can use all the resources. There's a way to contact them for more questions and more support that they offer that they've mentioned. Please do complete the survey. There's questions in there for three quick questions, 2 about what happened today and 1 about how other topics we might want to use. And let's see, before I wrap up and thank our presenters again, please do go to chcf.org/CIN to find out more about the California Improvement Network, particularly if you are new to this webinar and are here under someone else's connection with the CIN, somebody else's email invites to these webinars. There's a contact, there's a way to add yourself to the email distribution list from the CIN. It's a fairly low volume list, but it offers, it'll invite you to future webinars. It'll let you know about future workshops. There's good partner meeting reports for the 3 annual partner meetings. The one most recently published in November is actually about behavioral health primary care integration, which maternal mental health, of course, is part of that, and we learned about the 5 stages of integration or 5 levels of integration today. So there's more information about integrating behavioral health and primary physical health services in this really nice report that just came out. Lots of cool stuff, from the California Improvement Network. So please check that out as well. Tell your friends. And again, just in our final minute, thank you so much to Karen, Joe, Gabrielle, and Camilo for their great work. That's a huge resource for California, and they're making themselves available nationally now, which is great. So thank you all very much for joining us, and I hope you enjoy the rest of your day.
Thank you for having us.
Thanks.